Emerging trends and research directions for diabetic foot.
All right, thank you very much. And my only disclosure is that I'm the medical director for the Amputation Prevention Centers of America, which is a restorative health company. You probably heard me mention that we run about 235 wound care and limb salvage centers in 35 states in the U.S. This talk is not being sponsored by anybody. I do have a tip jar in front, so if somebody wants to sponsor it, you can put it in your tip jar. There isn't really any potential bias here. And then I want to discuss the emerging trends and research directions in the diabetic foot and prevention. So this comes from my hometown newspaper, the LA Times, and you can see that it comes from the business section of the LA Times, not the health section, but soaring diabetes rates wake the prosthetic industry. And this is the, you may have seen this before, but this is the first surgery caught on video. And it happens to be a below-the-knee amputation in 1901. It's Ernst von Bergmann, who, as you can see, I think back then, surgeons were better paid. He's obviously well fed, and but he is not wearing gloves. And I think, you know, at that point your anesthesia was a good schnapps. But it's been said that every 30 seconds, somewhere in the world, a limb is lost as a consequence of diabetes. Now, Diabetic Foot International has updated this. They say now in 20 seconds. You'll see that in a later slide. George Bernard Shaw, who's a playwright from Ireland, said that he marvels that society would pay a surgeon such a large sum of money to remove a person's leg, but nothing to save it. And that's still probably true in our pay-for-procedures type of reimbursement system as opposed to pay-for-prevention. So more recently, January of this year in Diabetes Care, there was an article that pointed out what seems to be now a resurgence in the number of amputations that are being performed in the United States. And if you look at this over time, sorry, it's cut off down there, but 2015 is the last year here. So between about 2009 and 2015, we saw a reduction in amputations all the way till about 2009, and then an increase in the total number of amputations. However, when you look at this in a little bit more detail, what we see here in blue, these are toe amputations, and red are partial foot amputations, green above the knee, or green are below the knee amputations, and purple above. You see that it's really an increase in the foot sparing amputations, the toe amputations and the partial foot amputations, that's driving this increase in amputations overall. And that's probably not a failure, but it's probably a success here that we're preventing major limb losses. Dr. Mintz discussed earlier about how amputations are extremely local, the prevalence and the rates of amputations. It's something that we call the zip code lottery. You know, if you live in one zip code, you have a higher rate of amputation. You live in a neighboring neighborhood. And this was based on a Kaiser Health population study, but covered very widely just a couple of weeks ago on all the major media outlets, including this one in CNN. So in order for us to target and understand where we need to work to prevent ulcerations and amputations, it's important to know the natural history of a lower extremity amputation in diabetes. And it's not a single-step process that just because you have diabetes, it will end in amputation. There's several steps that occur in between those two endpoints. The first is obviously the diagnosis of diabetes. After 8 to 12 years, patients generally would develop peripheral sensory neuropathy, which leads to unfelt repetitive trauma, and that causes an ulceration. Around 50% of these patients have significant vascular disease associated with their diabetic foot ulcer that requires some type of intervention, or should require an intervention. They don't always get the intervention. But it's almost always the infection, which is the coup de grace, the final blow, that leads to the amputation. And so when we look at this, the idea is to intervene at one of these steps and de-escalate someone's risk. And if there's an infection and we're treating the infection and have cured the infection, now we have to worry about perfusion. After the foot's been reperfused, we have an ulcer. When the ulcer is healed, we're down here in the neuropathy phase. And there's really no, we don't have any accepted treatments, I would say, that have been shown to reverse diabetic peripheral neuropathy and improve somebody's sensation enough to reduce their risk of ulceration. So you're probably going to be stuck at that phase. But the idea is to target our interventions there. And so this was mentioned by the last speaker, but I think it's important to note that the what is now called D-Foot or Diabetic Foot International used to be called the International Working Group on the Diabetic Foot. They still put out guidance documents under that title, and these are available for free on the internet. And these are international guidelines that were put together by subject matter experts for you to use in your own clinics. But it's not just that you can download these things and all of a sudden you're practicing at the best practice just by printing these things out in the clinic and having everybody take a read of it. Instead, what you need to do to create excellence, and this is what we focus on in a lot of our centers in America, is to take these guidance documents and digest them into something that you can use that does create excellence in your center and make sure that you're performing at the best practice. So how this works is you take these clinical practice guidelines, which are developed by societies or this international working group, and these things may not be applicable in every scenario or in every location. And so you have to take that and make it applicable to your practice and to your hospital or to your country, and you create a clinical practice pathway. And underneath the clinical practice pathway, now you can sometimes people make these clinical practice pathways, I'm sure you've seen them, which is a slide that you can't even read because the text is so small and there's arrows connecting everything to one another. And that makes it so confusing that nobody's ever going to follow that. And so instead you want to make these things as simple as possible, and even if you break it down into multiple clinical practice pathways within the same disease entity, you can do that, and we do that as well. We take perfusion as a pathway inside of the diabetic foot, and we have a pathway for infection inside of the diabetic foot. So they're not all mixed in one and another, because you need to go from one step to the next anyway, and you can't, if there's an infection, you can't advance to the next step without taking care of that infection first. So you create these clinical practice pathways, and then you write policies and procedures underneath those clinical practice pathways. It's going to help everybody on the team stay on the pathway. And the policies and procedures should be very specific, things about non-invasive vascular studies for every patient that comes in with a lower extremity ulcer, things like that. Now underneath that, you set up quality assurance measures that make sure that everybody is performing what's in the policies and procedures. Now quality assurance measures, you can only study things that can be measured. So some things are kind of opaque, and it's hard to get the data for those. But if it's something that can be measured and easily pulled from your electronic health record, for example, those are where you're going to set up those measures. And then you already have planned what your performance improvement is going to be if you don't meet those measures. And that's the best, recipe for creating a center of excellence or creating a model in which you're following the best practices. You might say, why do we need this quality assurance? Well, Carolyn Fife looked at several hundred wound care centers and wrote an opinion article about why is it so hard to do the right thing in wound care. Things that we know are the right thing to do, like total contact cast. Only 6% of eligible diabetic foot ulcers are getting total contact cast. Only 17% of eligible venous leg ulcers receive adequate compression. So we need to make sure that we're doing the right thing and then work on our performance improvement afterwards. So different quality assurance measures you can look at: percent of total wound healing over time, surrogate time points like healing in 30 days, median days to heal, other things that are modality based, but be realistic about wound healing rates, because when there's no national standard for wound healing rates, but when you look at another paper that Carolyn Fife wrote, looking at wound healing rates over 12 weeks, diabetic foot ulcers, only 30% of them healed. And these are in wound care centers, which should be the centers of excellence for this type of thing. Pressure ulcers, only 30%, and venous leg ulcers, 44%. So you have to be realistic when you're setting your own goals and what you're going to do. So in the last few minutes about future directions, I want to focus on prevention of recurrence of ulcers. Because once we've done a lot of talking about what we're going to do to get people healed, but once they're healed, they're at the highest risk for getting another ulcer. And we just spent all this money and all this time to do this, but how do we prevent the one from coming back? And you look at these studies, and these are studies over the course of as long as 5 years out from a healed ulcer, and up to 80% of patients will re-ulcerate at that point, up to 5 years out. So what we need to do is look at strategies to prevent these ulcerations. This is Paul Brand, who was an orthopedic hand surgeon, spent time in India. He discovered the link between neuropathy and ulceration in leprosy first, and then later translated that to diabetes. But he talked a lot about pain being a gift, and it's the gift that nobody wants. If they don't feel pain, we have to look for another way to warn you of tissue damage occurring, because normally your brain is set up to be warned by pain. So instead, now what we're doing is we can look at temperature, because temperature is one of the cardinal signs of inflammation, and an area on the foot always heats up before it breaks down. And so this is something that's brand new and very exciting. You saw the thermometer that I had prior to this right here. This is an older thermometer that's no longer on the market. It was used to predict ulcerations by measuring the same point on both feet, and anything greater than 2 degrees centigrade or 4 degrees Fahrenheit was considered significant for inflammation and could lead to a breakdown. So now it's a lot easier, because you just stand on this mat for 20 seconds a day, and the temperatures get uploaded to a server. It calculates this over a period of time, and Larry Lavery just finished this study looking at patients, and this was his earlier threshold was with using that other thermometer, and then these other 3 thresholds are using the mat, and you can see that we can predict ulcers all over a month in advance before they occur, based on the difference in the foot temperatures over time. And so the idea is that patients will get an early warning, and doctors will get an early warning that this patient is having a temperature differentiation that could lead to an ulceration. And with that, enough of that lead time, you can do something to prevent that. So these ulcers occur because we have these cycles of repetitive stress multiplied by pressure equals trauma. And when we translate that to a different way, it's really steps times pressure equals ulcerations. And so you take somebody that looks like this with a very deformed foot that's got a lot of pressure on the center of the foot, and this person can't take very many steps in a day without being protected before they would get an ulcer, because there's just an immense amount of pressure there. And so what we have to do is reduce the pressure and the steps, the pressure with either surgery or external devices, and the number of steps per day, and then that reduces the risk of an ulceration. So maybe the next step, and I think Dr. Najafi might talk about some of the wearable tech in the next session, but the next step might be prescribing activity like we prescribe a drug. And patients all are going to have a different ulceration threshold, and this is the difficulty with this, is that somebody with a horribly deformed foot will have a much lower number of steps per day that they can take versus somebody who has a relatively normal, biomechanically normal foot can take a larger number of steps per day. But perhaps, everybody carries an iPhone or an Apple Watch. The pedometers used to look like pagers, but perhaps it's where we're going to be risk stratifying these patients based on their pressure, and then prescribing the amount of activity they can take. And once they've reached a certain amount of activity, then they get a warning on their phone or their device that they shouldn't be walking anymore. So, in summary, these trends that I think that we're seeing are in healthcare are not really only in healthcare. I think that we're seeing these trends around the world where we have sedentary lifestyle leading to more disease, austerity from governments leading to less money to take care of these problems. There's a lack of trust in authority that we see, which results in reduced trust in doctors and reduced trust in industry. And these are all the challenges that we have to face that also translate into what we're doing in the diabetic foot. So I'll leave you with this. The left foot is also a Me Too, and make feet great again. So thank you very much.